Pharmaceuticals. I welcome everyone to yet another session of the no thrombosis workshop in acute ischemic stroke. As always, we are looking forward to have very interesting and unique case discussions today. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and wisdom shared by our course director. And it is my honor to introduce our faculty for today's session. So let me just share my screen. Yeah. So I first welcome our course director for today's session, Dr. N.R. Ichapuria sir. Sir is director neurology at Sahyadri Hospital, Pune. Sir has the first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. Sir has more than 300 public lectures and workshops on stroke. He has been a member of Indian Stroke Association. Sir was the organizing president of StrokeCon 2012 and ISH Stroke School. Sir is founder of the Pune Stroke Group and ex-president of the Society of Neurosciences Pune as well as Maharashtra Academy of Neurology. Sir has been a principal investigator for many multinational stroke trials like Perform, BrainsGate, BG12, etc. And Sir has recently awarded as a health icon by Times of India Group. I welcome Dr. Ichapuria sir to tonight's session. Then I welcome our first moderator for today, Dr. Anshu Rodgi sir. Sir is senior consultant neurologist at Sir Gangaram Hospital, New Delhi, and professor of neurology at GRIPMAR, that is Gangaram Institute of Postgraduate Medicine and Research. Sir is secretary of Delhi Neurological Association from 2021 onwards and joint secretary of Association of Neurologists in Clinical Research, Mumbai. He has been a coordinator for National Accreditation Board for Hospitals and International Organization for Standardization for Neurology. Sir has been a principal investigator in more than 24 studies like VitaTope, Profex, etc. Sir has over 47 publications in various reputed national and international journals. He has also presented more than 25 scientific papers at various conferences and has been a guest faculty at many prestigious neurological meetings and conferences. Welcome, sir.
Thank you.
Then I welcome our first speaker for today's workshop, Dr. Venkatesh Bolegave, sir. Sir is a consultant neurologist at Prakriti Hospital, Thane. Sir has multiple publications in various national and international journals, multiple poster as well as paper presentations at various conferences. And sir has won many prizes at conferences like first prize in National Conference on Headache, Cochin, and third prize in National Neurologic Quiz at Shine Conference, Chennai. Sir has also conducted a quiz competition for neurologists at AOMC International Conference, Mumbai. Welcome, sir. Uh, then I welcome our second speaker for today, Dr. Harsha KJ, sir. Sir is consultant and head stroke endovascular neurosurgery, neurosonology, neuroimaging at Brains Hospitals, Bangalore. Sir has professional memberships like Indian Society of Neuroradiology, Indian Society of Vascular and Interventional Radiology, Indian Medical Association, Neurological Society of India, and European Society of Radiology. Sir has been a co-investigator for more than 13 clinical research studies like Navigate ISIS, Respect ISIS, Point, Test, Tempo 2, Inspire, Restore Brain, etc. Sir has also published 18 articles in reputed national as well as international journals. And also he has on his name 25 case studies as well as letter to editors. Sir has also more than 6 paper and poster presentations at multiple conferences. With this short introduction of everyone, I would like to hand over this session to our course director, Dr. Icha Poria, sir, for the context settings and the opening remarks. Over to you, sir.
Yeah, thank you. We've had a break in this very wonderful program for, I think, 2 months because of this NMC regulation and all that confusion which happened. But we are very happy that, all these things have been resolved and we can get back to our academic work and discuss so many beautiful cases. We learn so much every time we meet here. And Anshu has been with us so many times. I think more than 50-60% of the time he's been the moderator. So we welcome him once again. And Venkatesh, I think this is the third time you're presenting a case. So we are very happy that you like to come here and show your cases. So we really welcome you, and we are really very happy to have you. And Dr. Harsha, as a neuroradiologist, I think we welcome you very warmly, and I'm sure you will give us a different angle to the cases that we discuss, and we are extremely happy to have you here and to present your cases. So I welcome all of y'all, and let's start with the discussion. So who's taking it first?
Yes. Dr. Venkatesh sir can take.
Yeah, Venkatesh, yeah.
Good evening, all. Am I audible clearly, sir?
Yes, yes.
And my screen is also clearly visible.
Yes, audible and visible.
Okay, thank you, sir. So, good evening, all. So, I'll be presenting a case. Again, scenario is unusual. So, to start, she is a 68-year-old female with history of diabetes and hypertension, who has presented now with acute right-sided weakness with aphasia within 2 hours of onset of weakness. At admission, her NIHS was 18/42, which is suggestive of moderate to severe stroke. Her blood pressure and sugars were blood pressure was 160/86 and blood sugars were 184. So with this scenario, patient within window period, clinically, we have her video. So RMO is examining the patient. So she has right-sided weakness. So complete aphasia with power almost 0 on the right side. So this was the patient at presentation. So we have CT. So we got the CT done quickly. So this was the CT scan. I would like to play a video also, the CT. This is not in-house CT. Patient was sent outside and then got back. So only CT scan plane was done. And as we see, there is no bleed. And this is large infarct. So obviously within window period, patient was thrombolized with 10 hectoplasm, 0.25 milligram per kg. And with that, in next 1 hour, this was the patient. So she did not require even Ryle's tube or Foley's catheterization. She was walking back on her feet. So relatives were very happy. So next day, MR angio was done and with MR diffusion, and we can see there is infarct which is established partially in the left MC territory, mainly cortical, and angio has showed large vessel occlusion. ICU we can't visualize. There is filling from the opposite side branches. So this was the scenario. A large vessel occlusion stroke thrombolized and got better. So the first thing was what next? So what will be the management? Whether she should undergo early DSA and stenting if required. Patient was started on antiplatelets. So what is the kind of duration? So what at earliest we can take her for intervention?
So, okay. So, what did you do exactly? Did you go in for intervention early or?
No, sir. Actually, the thing is, the setup where I practice, where these cases, only there is no in-house city or etc. Patient is a cash patient basically, so they don't have too much money. But they have been explained fully, and with the initial result with tenecteplase, they have been advised early DSA. But the duration which I told them, since there is major vessel occlusion, there can be high risk of recurrence even on treatment antiplatelets which will be given to her. So,
Venkatesh,
sir,
just get back now to the scans.
right, sir.
Let's see the first CT scan. Yeah. Now, of course, as you have said, there is no bleed, but also, can you see my pointer? No. Okay. So, in the CT scan also,
Right.
you should see for now, you see on the right side, you can see the gray-white matter differentiation.
Differentiation. Yes, sir.
On this side, you cannot see.
Right.
And sulci gyri are seen here on the right side. They are obliterated here.
Right, sir. Here we can see.
So, of course, the ruling out bleed is there, but you should also attempt to, now you see this Sylvian fissure. Yeah,
I think there is a possibly thrombus.
Just
in
go
the
up a
Sylvian.
little bit.
I think there is a thrombus in the Sylvian fissure on the left.
Yeah.
You can see, I think you can see.
Now you see here on the right side, you can see this gray white. Here you can't see.
I think in one of the cuts.
Sylvian fissure here.
I think, sir, in
well seen here.
one of the cuts, I think the thrombus bit doubtful, sir. Thrombus.
Yeah, just go down.
Yeah, there it is.
MCA
I think there you can see the thrombus. Yeah, you can see the thrombus.
So there is a MCA dot sign. So in the CT scan itself, very
you can
clearly
see it more
you
easily.
can see the dot sign.
There was
Just go down one more cut. One more.
There, I think there you could see. Here it's difficult to say.
Yeah. Even here, probably you can see the something here in the left carotid in the cavernous sinus.
Yeah. There is a hypertense sign.
Yeah. So in the CT scan itself, you can get a lot of information.
Right.
So here we would say her aspect score would be, let's see the upper cuts. Upper, ekdam upper. Right on top. Supraventricular. Yeah. Yeah. So maybe the Anshu aspect score of about 6 or so.
Yeah, sir. Even here you cannot able to make out the differentiation between grape. It is also getting effaced.
Exactly. So, and we are seeing an MCA dot sign. So already we know that it is an LVO, and the aspect score is about 6. So I think we need to go ahead, with thrombolysis, no doubt. But so much more information you should be able to get from a plain CT scan.
Right.
And ideally, if the aspect score is 6 and the NIH is more than 6, you should do a CT angio. I mean, I know it's difficult for everyone to do it because the scanners are not so good and all that. But all attempts should be made to do CT angio with a 3-phase CT scan, to show the LVO and to show the collaterals. So it gives you a wealth of information, and everything can be done within 5 minutes. You don't need to, in 5 minutes, you have that data. And when you do the CT scan, you should already give the TPA. You should already give the tenecteplase. You should not wait for the CT angio.
Right.
You give the tenecteplase and then you do the CT angio. So maybe you can instruct your radiologists, and to get their center little more tuned to stroke management, because I think this is very important.
Correct.
Now let's go back to let's go forward to your MRIs. Yeah. So more or less in the same area that we showed, or we were thinking and those are not infarcts, mind you. Those are early ischemic changes. It's within 2 hours, you said, no?
Yes.
Yeah. So
the CT was within 2 hours, sir. MRI was the next day.
Yeah. So, many times we see this diffusion lesion and patient has improved. So really many times I wonder, that this MRI, DWI is really not showing the true picture, and a lot of it is reversible.
Reversible. Yes.
So, because patient has made such a good recovery,
Right.
it's very remarkable. Now let's see the angio, MRI angio.
This
I couldn't see it very well, but you could show it a little better.
so we can
Yeah.
left ICA.
Now, where is the ICA?
This one. This is common carotid. And from here now, ICA we can't see.
No, it's
And
not
this is
seen
neck.
at all, So
No?
You can't see the IC actually.
Yeah, so question of stenting here does not arise because you can't see it. So ideally, you should do a CT angio after this or a DSA.
Right.
I mean, CT angio is easy to do, it's non-invasive. And if you see flow and if there is critical stenosis, then definitely we would like to do revascularization. But here we are not seeing the vessel.
Yes.
So, but one thing you must realize that MR angio time of flight pictures always overestimate the lesion. And, you don't see flow in MRI, but you may see it in CT angio or DSA.
Correct.
Dr. Harsha, would you agree with this statement?
I think he's
Yes,
on
sir. Definitely.
Yeah. Dr. Harsha?
Yes, sir. Definitely, I agree with you, sir.
Yeah.
So,
So Venkatesh, I think
right,
you will have to take it to the next level.
Correct.
You'll have to do more imaging to, determine whether really she needs revascularization or not.
So how early after thrombolysis we should advise for or immediately?
The thrombolysis effect has gone away in 24, 48 hours.
All right.
So, we would like to do it within the first 15 days.
15
because,
days.
I think
2 weeks. Generally, we say,
for
sir.
too long doesn't give benefit.
I think anytime after first week you can do it. Anytime
Right.
between the first and the third week.
Same.
And the thing is that you need to load them with the antiplatelet before you consider them for even this thing. So I think you will be on double antiplatelets. And
Right,
after the first 7 days, you can plan to do angio and angioplasty.
Yeah.
Correct, sir.
And another thing I wanted to say, so maybe on the second day, next day, you can give dual antiplatelet.
Right.
And then you can take up the patient. Another thing is, this is extremely gratifying to you, that the patient improved so well. And this is called VENI, very early neurological improvement. This occurs in about 20% of cases. So, it's one of the most gratifying things to see. The person has come paralyzed to the emergency room. And in the emergency room, only the patient has started walking.
Yes.
So, Venkatesh, they will bless you for the rest of their life.
Yeah. So, obviously, sir, with this scenario and with the facility available, because there is no city in hospital, and they were happy that the immediate CT was done and she was walking back.
So it's a very happy thing to see. I mean, all congratulations to you for acting fast. Even though you don't have inside CT, to get the CT, get a bag. In fact, you should take the tenecteplase to the CT scan department and give it there. Don't wait for patient to come back. You'll waste another 15, 20 minutes, 1 hour, God knows how long. How far that CT scan center is, we don't know. And with traffic and rain and this and that, and hajar problems that India has, we don't know. So you should take the tenecteplase with you and give it in the CT scan as soon as you see that there is no hemorrhage.
Yeah, we recently had a very interesting spin. We had a 94-year-old man, and
Just
we were
speak up
very
a little
reluctant.
loudly, Anshu.
So we had a 94-year-old person, 94.
Ah.
So he came early morning. His attendants, we were a little reluctant to thrombolize him, but his attendants were very, very keen that we thrombolize the patient, and he did extremely well. Really improved. He had an MCA thrombus and did extremely well. We were very surprised. We were very worried to thrombolize a 94-year-old person last week only.
Yeah, so there are these miracles here. So, okay, then what happened?
So, like we have discussed, sir, I told them within 15 days you should get DSA done. Money was the issue, sir, main for DSA and for the stenting. But with the result, they were agreed to that. And after 5 days, she did completely fine. During hospital stay, there was no issue. Blood pressures and blood sugars were under control. Blood pressure was maintained around 150, sir. And she went walking to home, sir. And so next day morning, again, she presented with a right hemiparesis. So recurrence of stroke on the same side. A physic. So again, she had recurrence of stroke on dual antiplatelets, and she was thrombolized 5 days back. And we know that there is large vessel occlusion. And again, the money was the problem. This is next day. They went home at night, and in the morning they were back. And so again, urgent CT scan was done. BP was okay, GT was okay, NIHS was coming, and this was the CT scan done immediately, like within 2 hours again. So this was the scenario. Money was the issue. Patient is back to you with the CT scan. DSA and on stenting, etc., is not possible. So what next?
Very difficult situation.
And patient's relative were very happy with the first result. They were explained with great detail in the first setting only. Again, I explained to them, okay, this is the scenario, and they have to take a call. So I told them, generally we don't do the thrombolysis immediately within 3 months of patient who was either stroked or had thrombolysis. So everything was explained to them. The patient was complete aphasic with again 0 power on the right side.
Yeah.
Bed bound.
Any more imaging? Because
So,
there's a clear-cut infarct now.
Infarct, yes, sir. It is.
Yeah, clear-cut.
We have CT
infarct.
only, sir. CT plane was done at.
CT only. I think it may be the old infarct which she was having.
It may
on
be the
diffusion.
old one. It may
And
be
I think even you just there is a thrombus again. You can see the thrombus again.
Yes.
And it's possibly the thrombus is also, because now you can clearly see the thrombus. You can go up to higher cuts. Even the higher branches of EMS, you can see the thrombus even higher up, or higher, even higher. So did you re-thrombolize?
So that was the thing. Relatives were caught up in the issue of money, and then I discussed with them. You have a chance because patient was completely aphasic with 0 power on the right side. So and with CT scan showing, like you said, this could be a old thing, and they were within. This was kind of, they are now within almost 1.5 hours. We got it done, everything. So I told them this is quite early. You take a chance whether if you want to thrombolize or not thrombolize. Guideline says you should not thrombolize. So with relative discussion, it came from their side ki go ahead with thrombolysis. I told them we'll take a chance, whatever is the thing, high risk concerns, etc. taken, and out of way. And I told them we are going out of way and doing the things. and she was thrombolized with tenecteplase again. So that was the scenario, sir.
So how did the patient, did she improve?
Yeah, so this is the patient post thrombolysis. This was immediate. So this was the patient post thrombolysis. So next, even after second thrombolysis, patient had improved, and then the patient was immediately shifted to a higher center for further management. So what should be done and how to manage that scenario?
Okay, so what does the CT angio show?
Yeah. If common carotid, you can see. Sorry.
Yes, you have some other views.
This single, sir, actually.
There, I think you can.
Yeah.
There, I think I can just go up one step back. I think you can see that. Yeah, I think there it is. Move slowly. Now the NC has opened up.
Yeah.
So there is a stenosis, significant stenosis.
Yes. So patient was again was thrombolyzed. So how to manage this scenario, and whether we should consider the kind of stroke which we are dealing with, like if patient did very well and there is no much infarct on initial
I
scan.
think still, as I told you last in the first time
Yes,
also, that after
yes.
7 days, I think we can very well go in for an angioplasty. I think we should be more aggressive. We
Aggressive.
should not wait for. We should make things happen, not wait for things to happen.
Yes. Right. So these are the patient hair centers. So she was again walking. So she was advised DSA, and we can see here there is significant stenosis at the origin.
Origin, there is a stenosis.
Yes. And she was stented, and this was done like after around 3-4 days of second thrombolysis. So they were sent to higher center where she was stented.
Yeah, very critical stenosis.
Yes.
Yes.
Very critical.
Right.
And probably there is an ulcer here, I think. Of course, here it's very critical. Almost 99%. That's why she's getting those stuttering strokes.
Yeah, right.
So it is artery to artery embolism.
Yes.
It's not hemodynamic stroke. It's artery to artery embolism.
Artery.
So,
Yes.
So yeah, with such a bad vessel, even the first time, the indication to do the intervention and revascularization was there.
Yes.
Now, waiting for some time is a risk.
Risk.
Definitely.
So that 7 to 15 days time should not be said. At least DSA should be done,
No,
and then
I think, I mean, if it is so critical, we can do it early also. If the
Early
infarct
also.
is not big, patient
Big.
has recovered. See, what are we worried about? We are
Yeah.
worried about when you revascularize, there will be hemorrhage
Yes.
in the infarcted area. That is the only thing we are worried about.
Right.
But if you manage the BP well and all, I think that hyperperfusion syndrome, I mean, it's a risk. It happens. Hyperperfusion does happen. But the way to prevent it is to do very good control of blood pressure.
Right.
So anyway, we would like to revascularize soon. I mean, whether to do it in 7 days or 5 days or 10 days now, it's very difficult to answer that question.
Yeah.
But we would like to do it as early as we think it is safe. I think that would be the best answer. To put a numerical value would be very difficult. But this stenosis is so severe. I think it is 99.9% or 99%.
Thanks. And what regarding erythrombolysis, sir? How long like you said, we should look at the infarct, what patient had initial thing, and then decide the duration, because that 3-month period again, I don't think so. It was
All
arbitrary
those things
period.
are very old.
Old arbitrary period.
Yeah, they are very arbitrary. See, nobody's done a trial to say, okay, if you do it in 1 month, bleeding will occur, and if you do. See, these are all conjectures. Who has done a trial?
No.
Nobody's done a trial. Why these things came? Because they wanted the initial trial to be successful. Without producing harm.
Yes.
So therefore, all these conditions were put in. Now these conditions have become weaker and weaker, and as our knowledge has grown, and as we are seeing more patients, that time they saw only some 100 patients or 200 patients. You can't make a judgment on that. Now we are seeing thousands, and after thousands of patients, each patient is different. I think, though it's not written down, if you take family into consideration and use little common sense and discretion, I think many of these guidelines will have to be rewritten. And they are not rigid. No guideline. It is a guideline. It is not rigid. It is not written in stone that you can't do it. It can never be done. ऐसा कुछ नहीं है. So
these are actually relative contraindications.
Yeah.
But I must say that you were bold in giving the tenecteplase second time again. Maybe I would, if money was not a problem, I would have done direct MT or something.
Yes.
But I think you've been very innovative, and in a resource poor country, I think IVT, is really the way to go. All these interventions, they jump on my throat, when I say that. But we have seen it umpteen times. Anshu, how many times
we recently had a patient.
LVO opening up with tenecteplase. Umpteen times on this show we have seen, and also in practice we have seen umpteen times that it improves. So
the one patient I was talking about, the 94-year-old person, he had an MCA thrombus. The intervention said, I'm not going to touch him. So we didn't. And the family was very willing, so we went ahead and did it.
Yeah.
He's done extremely well. He came yesterday to the OPD and he's all fine.
Yeah, so I think Venkatesh, you've been very bold, and I think you have done a good job with all the hurdles in your way. Not having insight CT scan, not having money, that, all these mounted very well, and congratulations to you. Dr. Harsha, would you like to comment?
No, sir. Whatever decision
What would
taken
you
at
have
that
done in
point
the
of
second,
time,
when the second stroke came? What would you have done? Suppose money was not an issue.
it's a difficult situation. Probably I would have thrombolized.
Huh?
I would have thrombolized.
You would have thrombolized or you would have done empty direct?
Thrombolized still, because the empty
You know,
takes
now
more
thinking back,
time.
empty also would have been difficult. You
more
would have
money.
had to put, you know, for the balloon to go through, for the
Yes.
thing to go through, you would have had to put in a stent first, or at least dilate the ICA,
Yes.
and then go across it. So, you know,
Yes.
that also increases the risk, but it can be done. I mean, not that it cannot be done. I mean,
Yes.
you do double, what is it called? What's that name? Double, you know, when there's a lesion in the MCA and there is a
Tandem.
lesion in the ICA.
Tandem
Occlusion.
Tandem occlusion.
You do it. So this is a classical case of tandem occlusion.
I think then they would have done angioplasty first and then maybe gone it for MT. They might need to have to done the angioplasty first before they went for.
Yeah, so balloon angioplasty first, go across the stenosis and then do the MT. If money was not the problem, I think I would have done that.
Yes, sir, definitely.
But you know, I must say that you were bold in giving the second TPA, the second tenective place so early. So it is something for us to learn also, that it can be done. Don't bloody listen to guidelines all the time and, you know, throw the book at the person. I mean, it's a guideline. It's not written in stone and it cannot be, it's not a 10 commandment that you can't change it. Aisa thodi hai. So good.
So I have gone through literature after that.
Yeah.
And I could find a significant amount of data. So there are multiple case report and case series which were done. This is from the stroke. Even they have gone and even ethic committee permission they have got for some studies. I don't know. And the thing which I have found was the risk of bleeding, whatever studies they have shown now, was very less or nil, sir, as symptomatic bleed. So improvement may or may not be there. It was a thing, but the main worry which we have is rebleed. So they have not found, and the earliest erythrombolysis was after 4 days, sir.
So I think the point here is, I think if you go back to the study, it shows small infarcts. So if you have a moderate to large,
obviously, yes.
Yeah, if you have a moderate to large infarct, then you can have a problem.
Then we have worried,
yes.
But
then
small
you can have a
infarcts,
chance.
I think you
For
can
small
do.
infarcts, there is not. I don't think there is an issue.
Yeah.
It is only, even if you look at those guidelines, they're talking about moderate to large infarcts.
Yeah. Right. A number of studies that I could find literature wise.
Yeah. Yeah. So wonderful. Yeah. Thank you. Thank you, Venkatesh.
Thank you.
Thank you. Yeah. Dr. Harsha, can we go ahead?
Yes. I think Venkatesh has to stop sharing.
Stop share. Yeah.
Then I can share. Good evening, all. Myself, Dr. Harsha. So after completing neuroradiology, I went to Canada for stroke fellowship, and now I am working with Dr. Venkatramana in Brian Super Speciality Hospital in Bangalore. And sir has asked to give regards to Dr. Chaporia sir, that he knows him very well. Dr. Venkatramana is a neurosurgeon, sir. He is practicing in Bangalore, so I think you must be knowing. So I'm working with him, and I'm taking care of the stroke and vascular neurology, along with the neurointerventions. So again, out of the guideline case, the case history starts with this gentleman, 64-year-old. 2 months back, he was in USA at that time. And one evening, he developed a speech difficulty, right facial drooping, and right sided weakness. and he was in USA at that time, and he was taken to a local hospital there within minutes. He was diagnosed as a major stroke due to large clot in left M1 MCA. And the discharge summary says that the clot was removed within window period by mechanical thrombectomy, though I was not able to see any images, and following which he dramatically improved and completely improved. So TP was not
You
given.
could speak little loudly, Dr. Harsha, little loudly.
Sure. So the TPA was not given there in view of ACOM aneurysm. So they had done a CT and CT angio, and they had found an ACOM aneurysm in the CT angio. So that's why TPA was not given in spite of he being within window period. He was directly taken to mechanical thrombectomy. And it was written that TC3, that is complete revascularization, was achieved. And he was started on medicines, and he was discharged. And the medicines were cosprin and statin. So after that, his evaluation was suggestive of only dyslipidemia, prediabetes, stroke workup in rest of the things, including Holter 24 hours echo, were normal. So he was on atorvastatin and aspirin, and then discharged. So he came back to India 15 days back. So before he presented to us. And after coming to India, he stopped all the medications. And he was told to follow up with an Indian doctor for aneurysm and stroke, but he thought he will do it a bit later. So on 22nd evening, again, he developed right-sided facial weakness, right-side upper limb and lower limb weakness, and slurred speech. So he reached a nearby hospital, not our hospital, where he was taken up for MRI. He reached apparently within window period because they knew window period was important. And MRI showed a small new infarct in the left basal ganglia and a small old infarct in the left basal ganglia. Again, from there, he was shifted to our hospital. IV thrombolysis was not given there. And when he reached our hospital also, he was still within the window period for IV thrombolysis. But again, in view of history of ACOM aneurysm, I also didn't thrombolyze him. And his NIHSS at the time of presentation to our hospital was 12. And because already an imaging was done and already there is a known history of ACOM aneurysm, so I did not thrombolyze. I directly took him to cath lab. And I thought there will be again complete M1 MC occlusion, and again I have to go ahead with mechanical thrombectomy. But this is what I found in the first angiographic images itself. So it showed a thrombus. There was no fine lumen or nothing. It's probably porous but completely occlusive thrombus, and we can see contrast going beyond the thrombus. We can see here the ACA is very well filling. The opacification is good, and all the branches are very well seen. But here the opacification is not that good in MC territory, because probably the flow is going, but still not good. And this is the ACOM aneurysm. Not just this aneurysm, there is also another aneurysm in the PCOM region, which is a bleb-like aneurysm. So there are basically two aneurysms in this patient, and this thrombus. So actually already the contrast was going, so probably it was porous thrombus. And in such cases, the best option would be either aspiration. Stent river may not catch this small clot. In fact, while trying to pass the microcatheter, this may break and try to go into the distal aspect. So the best option was aspiration. But I thought, because it's a very porous and there is already a blood going across the thrombus, so I took a microcatheter and placed it just before the thrombus. And then I gave a tenector place. I thought I will give maximum of 2 mg in him, but I gave 1.5 mg maximum. After that, this angiogram shows that almost the thrombus completely dissolved. And with that itself, I was able to achieve. And even if I had tried mechanical thrombectomy or aspiration, I had a doubt that because this is so porous, so I may not be able to suck it, or it may get fragmented and go distally, where again I will have to probably use a small dose of thrombolysis. So instead of that, I thought directly I will go ahead with a small dose of thrombolysis, and I gave 1.5 mg of thrombolysis over a period of 15 minutes, slowly, just proximal to the thrombus. Again, recently there is a significant relaxation of these relative contraindications. Actually, recently, aneurysm is only relative contraindication, like how Venkatesh showed us the recurrent IV thrombolysis cases. So, if you search literature, there are again many cases where in the aneurysm, where people have done thrombolysis. If this patient had only CT scan, plain CT scan, and there was no details about his vasculature, probably in the first case also they would have thrombolized. Even I would have also thrombolized. And many cases and case reports are there in the literature where even with aneurysm they have thrombolized successfully. So that is now considered a relative contraindication. But because already there is a common reason with the prominent teeth, and people have denied, so I didn't dare to give IV thrombolysis directly. Instead, I thought I will go ahead and give intra-arterial thrombolysis. The patient did extremely well. So post-procedure NHSS came down to 1 immediately, and after 7 days didn't show any atrial fibrillation. Sleep study did not show any OSA. So his risk factor was still only very few, dyslipidemia and pre-diabetes. I was planning for elective aneurysm management. The patient is yet to come back for elective aneurysm management. Once the aneurysm is managed, probably dual antiplatelets might be safer, but he currently on only single antiplatelet, and the etiology still don't know. So it may be previously also there was only left M1 MCA occlusion was there. Now also there is left M1 MCA occlusion. So I was thinking if there is any local vessel pathology. I think vasculitis work was done in USA. That was also negative. So I was planning to do vessel wall imaging when he comes back later. But as of the etiology is concerned, it's still unknown. We don't know whether it's artery to artery or heart to artery. His echo, all the investigations for stroke were negative. So again, in this case, very interesting that patient, even though he's very intelligent and educated, and he is very highly placed. So visits US and then gets thrombolized there, gets mechanical thrombectomy there, comes back from the stroke, but still ignorant enough to stop the medicines and not to get any follow-up, and again lands up in stroke, again recovers. Only few times I think this happens.
So, Dr. Harsha, you had reviewed the literature. What is the dose of tenecteplase that has been advised to be used intra-arterial? Like, is there any standardization to that?
No, sir. No, actually, intra-arterial, not much of studies or randomized control trials recently, no guidelines, especially with tenecteplase. There are absolutely no upper safe dose, nothing like that.
Because we had, I think we had one similar case a few months ago where from one of the interventions from Hyderabad, he had also given an intra-arterial tenecteplase, and I think that also worked. So just wondering, you had reviewed the literature. What is any dose which is advised?
No, sir. No, sir. No.
And
Actually, the advantage of intra-arterial thrombolysis can be given even beyond the typical window period of 4.5 hours. So we can give up to 9 hours, 10 hours. So because the dose usage is less, like usually I keep a standard of 1/4 of the maximum allowed dose for intra-arterial. So approximately 4 milligrams, I keep myself as upper limit, beyond which before I go, I think twice, but up to 4. But in this case, because there was aneurysm, I thought I'll use only maximum 2 mg, but with 1.5 mg only it got opened. Just an arbitrary thing. There is no such a rule or study guideline how much dose to be used.
Yeah, as you said, non-ruptured aneurysm is not a contraindication actually.
Yes, sir. Yes, sir.
So what was the
Nowadays,
size of that aneurysm
about
diameter?
3.5 millimeters.
How much?
3.5 millimeters.
So it is not a contraindication. I think up to 5 or 7 millimeter, it is not a contraindication. And
Yes, sir.
it
Yes,
has
sir.
occurred in the same area, no?
Yes, sir. Yes, sir.
So probably it is an ICAD because it's not likely to be embolic.
Yes, sir.
Mostly
Yes,
it
sir.
is an ICAD which has,
ICAD.
closed
Yes, sir.
again. And maybe you'd have to, if it's recurrent, maybe you have to
antiplatelets.
put in a stent there. I
Yes,
don't
sir.
think
Yes,
it is
sir.
vasculitic because, he's atherogenic. He's
Yes, sir. Yes, sir.
65, he's pre-diabetic. What else did you say? Risk factor?
Dyslipidemia.
Hyperlipidemia, hypertension. So in India and in the east of the world, not west, ICAD is common.
Yes, sir.
It's of course more common in China and Japan, but in India also it is common. So mostly this is ICAD which has closed again, and maybe we could have given IV TPA also and got away with it, IVT, and got away with it. And if it is recurrent, you may have to consider putting in a stent there. And
Yes.
let's see, but many times I've found that, with good glycemic control and with good, statin bringing down LDL to really low levels, 40, 50, 60, many of these ICADs, they stabilize and they may even improve. So, atorvastatin is only on 40. So you can perhaps go up to 80 and you can use these newer drugs, the
Pompidolic acid.
PPASI inhibitors, and, bring the LDL really down, 40 also, and stabilize the plaque. And many times we have seen that even the plaque changes. It is not static, If it is non-calcified and it's just fibrotic and the plaque is unstable, you can stabilize it with dual antiplatelet, good lifestyle changes. We forget that. Was he obese? What was his BMI, Harsha?
It was definitely higher, sir. Not normal.
So, with good glycemic control and lifestyle changes and high dose statin and dual antiplatelet, maybe even celestozone, maybe we can stabilize the plaque. And if it doesn't stabilize, yes, then you put in a stent. But I wouldn't rush in too much. I would, give the best medical treatment, as we call it, and really aggressive best medical treatment. Aggressive. And you said he had stopped the drugs, no? What did you say?
He had
stopped the drugs. See, that is the most stupid thing to do. Stopping medicines after a stroke is a big risk factor for recurrent stroke. Stopping antiplatelet, even he was on single antiplatelet, only 81 milligram of aspirin, only 40 milligram of atorvastatin, and even that he stopped. So that is a big risk factor. Stopping medicines for secondary prevention is a big risk factor for recurrent stroke. So I think it's atherogenic only, atherosclerotic only, not vasculitic. I don't know how much this vessel wall imaging helps. It's open to so much criticism and interpretation. Is it vascular? I don't think it's vasculitic. I mean, he's clearly atherogenic, and we must be very vigorous with that.
I wanted to start dual antiplatelets, but this aneurysm is coming in the way.
So no, you can give dual antiplatelet. Maybe you can do that, clopidogrel resistance test. Maybe you can give Prasuj, this thing, ticagrelor, and more aggressive. If he's got resistance to clopidogrel, maybe you can think of Brilinta, and be little more aggressive in him and
aggressive.
counsel him that, Baba, you cannot afford to stop the drugs, otherwise. So I think this would be it. Anshu, would you like to give comments?
I think you are absolutely right, sir. I think he did the most foolish thing is stopped the antiplatelets.
Yeah.
And because and it looks like atherogenic only. And I think maybe we have had patients who have been, before all these stents came in, we have had patients who have been maintained well with MCA disease on for 15, 20 years on good medical management. So we've had patients. So I think I think maybe best medical management may be the way forward till the time
Yes.
you manage the aneurysm.
Yes. Agrees.
Yeah. I think we've had two very
Okay.
wonderful cases and so many things to learn from both these cases. And really, we are very, very happy to be part of this very nice discussion that we had. And I hand it back to Dr. Ajinkya.
Yes, thank you, sir. As usual, sir, it was a very wonderful workshop, and the online view count for today is 140. I am sure all of our audience must have been benefited, and we got to know many important things about intravenous as well as intra-arterial thrombolysis. I would like to thank Dr. Harsha sir, Dr. Venkatesh sir for presenting those interesting cases. Thank you so much, Dr. Ichapuria sir, Dr. Rodgi sir, for your expert comments and great practical insights. And working under your guidance in many such future programs would be an absolute privilege, sir. So with this note, we will close this session. Thank you everyone again. Bye. Good night.
Thank you. Good night. Good night.
Thank you.
Thank you.
Good night. Thank you.
Recording stopped.